Hello, my name is Kaylee Campbell, and this is my final project for CM 585A, Addictions and Substance Abuse, and I will be presenting on the case of Sarah. I'm going to begin by introducing you to Sarah. She's a Caucasian woman in her mid-30s who has lost and gained the same 5 to 15 pounds for over 20 years. Sarah's laxative use led to almost dying in the hospital from an overdose, and the hospitalization forced Sarah to leave school, and she has not since returned. She currently works as a sales associate at a retail chain. Sarah's moods have been described as a constant yo-yo, and binging has led to chronic depression and suicidal despair. Sarah also lost her longtime relationship due to the secrecy of binging, depressed mood, and irritability. She has not had any long-term relationships since and has begun avoiding her family as well. Although Sarah understands that the behavior is unhealthy, she claims it's her way of coping with the numerous emotions. She's suffered many relapses and sought out counseling to reinforce the idea that her current coping skills of binging are enough to manage her mood swings. Looking into diagnostic factors, many of them are going to be similar to the introduction I just gave, but I do want to focus on the more current ones that would be considered when diagnosing Sarah. So she does eat normally around her friends and binges in secret. Her moods, like I said, have been a constant yo-yo, which have led to chronic depression and suicidal despair. She has isolation and familiar relationships and many failed romantic relationships. And she reports never allowing herself to get close enough to another person for them to discover the truth about her eating behaviors. She also has an awareness that this behavior is unhealthy. One thing that we would specifically need to look more into is what a binge looks like to Sarah. We are not given much information on that in the case study, which could really impact how the diagnosis goes. But according to the DSM-5, binging is defined as eating quicker than one normally would, eating until uncomfortably full, eating a lot even when not physically hungry, eating in isolation because of feelings of embarrassment and shame, or feeling disgusted, depressed, and guilty after eating. The case study does not really address those first 3 points of how quickly she's eating, how full she feels after eating, and eating when not physically hungry. However, it does specifically talk about eating in isolation because of her feelings of embarrassment or shame and feeling depressed afterwards, which I will go a lot more into depth once I begin going through the diagnoses I have come up with. Next, I'm going to be going through a couple possible assessments that I would use in the beginning of counseling Sarah. So this first one is the Eating Disorder Inventory 3, or the EDI 3. And this is going to be one of the first ones that I really look at and go through with her, specifically due to her past hospitalization and bulimia and purging with the laxatives. So the EDI is used worldwide for both research and clinical work, and it's a self-report questionnaire that assesses eating disorder relevant psychological traits. There are subscales of low self-esteem, personal alienation, interpersonal insecurity, interpersonal alienation, interoceptive deficits, emotional dysregulation, perfectionism, asceticism, and maturity fear. So I believe that these could really be useful to kind of get a gauge of exactly where Sarah stands at the current moment, and also kind of help lead more towards the proper diagnoses instead of assuming anything based upon the case study. Sarah also consistently binges in secret, which can kind of reflect back on that shame of her binging, which I kind of would want to talk more to her about where that shame stems from, and the EDI 3 would really help open up that conversation. Now, this is a self-report questionnaire, and it has been extremely researched, and it's very easily accessible, so she could take it herself. However, I believe that personally, I would be able to get a little bit more information if I were to give this to her in a counseling setting. And then we could talk about each of the questions and kind of have that more open discussion rather than her just filling out the questionnaire on her own. The next assessment that I would like to use would be the Patient Health Questionnaire, or the PHQ-9. This is a short, self-administered questionnaire similar to the one previously talked about, and this assesses depression symptoms. The PHQ-9 test is widely used because of its high validity and reliability, and it contains 9 questions, hence the PHQ-9, but it contains 9 questions that all directly correlate to the criteria needed to diagnose major depressive disorder or any severity of depression. There are 8 questions that directly assess symptoms of depression, and 1 question that assesses how any depressive symptoms have been impacting the ability to function for the individual. For each question, there are 4 choices to choose from. These are not at all, several days, more than half of the days, and nearly every day. Each of these responses give you a different score, and then once they're added up, it has the capability of indicating if Sarah has anywhere from mild to severe depression, if at all. In the case study, Sarah states that she has chronic depression and suicidal despair. As her counselor, I would kind of take this with a grain of salt, and I would like to diagnose her myself and kind of talk about all of the symptoms and all of the diagnostic criteria with her to kind of see which fits and which doesn't. This assessment would give me either information needed to rule out or kind of rule in and go with that diagnosis that was previously given. In the beginning, when I read the case study, major depressive disorder was one of the first things I kind of thought about. However, we weren't really given any information at all in regards to the duration of the feelings, how constantly they arise, or really any diagnosable information. So I was thinking about putting it as one of the rule outs for her diagnoses, but I truly don't think that we were given enough information at all to even talk about it that in depth. But I do believe that if I gave Sarah this questionnaire and went through it with her, that there is a very strong possibility that I would be able to diagnose her. However, with the information given, I really don't think that that's possible as of right now. Going into the ethical standards and cultural considerations, there are a few topics that I want to touch on. The first one is confidentiality, which in the Code of Ethics is defined as counselors do not share confidential information without client consent or without sound legal or ethical justification. I thought that this one was a very important one to touch upon, especially with the level of care that I am going to be discussing later on in this presentation. Sarah has begun isolating herself from her family, and one of the aspects of the level of care that I chose is family therapy. And I figured that confidentiality especially would be very important in this because Sarah is a mid-30-year-old woman, and as everyone does, she has the right to her own confidentiality, and she has the right to share with them what she wants to share. There must be a reason that she has begun isolating herself from them. So I wanted to touch on this one as an ethical standard, just to kind of enforce that idea that it is her journey, and she has the ability to share whatever she wants. It's not our job as a counselor to try to inform her family unless, of course, she does plan on hurting herself or anybody else needs to be brought in that would kind of make it like that life or death situation, which of course then we have to breach confidentiality, but that would be talked about with her beforehand. But for the first aspect of this, I thought that confidentiality would be extremely important to touch upon. And then the next one is counselor awareness, which is defined as counselors are aware of their own values, attitudes, beliefs, and behaviors and avoid imposing values inconsistent with counseling goals. Eating disorders and really anything that has to do with someone's self-image can be very difficult at times for counselors to kind of work with due to their own personal beliefs and their own personal self-image. And I thought that this one was really important to put in place, especially just from my own personal experience of having a counselor kind of impose her own opinions on what someone should kind of look like and what the social standard is, I guess, for what people consider to be attractive. So, understanding exactly what you're counseling, and if you don't understand, seeking supervision and seeking outside help, and not kind of going above your own knowledge base is going to be extremely important. Um, since this is an addictions class, and Sarah wouldn't particularly present to an addictions place, she would most likely present to just a mental health counselor. Um, it is very important that once you kind of start to see that addiction side coming out, you reach out to someone who does specialize in addiction, regardless of the case, not just for the case of Sarah, but regardless of the case, because understanding your own awareness as a counselor is extremely important and can honestly impact the client in a very negative way if it's not gone about correctly. I'm going to start going into some of the possible diagnoses I had thought about, and what I believe would be the best fit for Sarah at the current moment. So, at the very beginning of this class, after reading the case study, I instantly went to bulimia nervosa. It was kind of the easy option in my eyes, just based on what I was reading, based on her history. However, of course, that is absolutely no way to diagnose someone, and you can't diagnose someone based on their past. It has to be based on the current symptoms and diagnostic criteria that they are presenting. So, using bulimia nervosa now as a rule out, I have listed the diagnosis criteria. And so the first one would be recurrent episodes of binge eating, categorized by both eating within any 2-hour period, any amount of food that is definitively larger than what most individuals would eat in a similar period of time under similar circumstances, and a feeling that one cannot stop eating or control what or how much one is eating. So, in regards to Sarah, she does have recurrent episodes of binge eating. However, we are not given any information on how often that is, how much that is, what a binge looks like to her, and her feelings surrounding it while she is binging. So, we can't diagnose her or say that she has the criteria to meet A. Next is recurrent inappropriate compensatory behaviors in order to prevent weight gain, such as self-induced vomiting, misuse of laxative, diuretics, and other medications, fasting, or excessive exercise. So in the past, Sarah had used laxatives. However, that is no longer the case. She got hospitalized, and then when she was released, she has had relapses. However, it has just been binging per the case study. So I am not 1000% sure that she no longer purges, but based on the information given, she does not meet that criteria either. The binge eating and inappropriate compensatory behaviors occur on average at least once a week for 3 months. Again, we don't have the information needed to be able to justify that. Self-evaluation is unjustifiably influenced by body shape and weight. Again, we really don't have the information given that we could justify that. In the past, it was weight-based. She used laxatives in an attempt to control her weight. However, there is nothing present that says that she is concerned about her weight. And this disturbance does not occur exclusively during episodes of anorexia, and she does not. So, if we were to kind of look into if she was in partial remission after full criteria were previously met, some but not all of the criteria have been met for a sustained period of time. She really doesn't fully meet any of the criteria, so we can't state that. And then for the severity, we would need to speak more to Sarah in order to get a full understanding of the frequency and exactly what she considers a binge, in order to really diagnose her with any level of severity for any of the diagnoses that I'll be talking about. Yeah, we would need a lot more information in order to kind of justify any of this. But this was a very good rule out. Again, it was my original thought process and fully based on her past, which I know you can't do, but it was still very interesting to kind of look through the diagnostic criteria and see which ones I could kind of relate and which ones were immediately a rule out. The next diagnosis I want to talk about is binge eating disorder. This one was really my second thought to go to right after bulimia, which I feel like is kind of a given just because she has symptoms of bulimia just without the purging, which would only be binge eating. So that let me hear. But I do kind of just want to go a little bit more in depth on binge eating disorder and kind of how it relates to Sarah and what else I would need to properly diagnose her. So binge eating disorder is the most prevalent eating disorder, and it occurs at equal frequency among Black and white women in the United States. And I got that information from Striegel and Moore in 2003, which I will cite below. But the criteria of binge eating disorder, for A, it's recurrent episodes of binge eating. So that would be characterized by eating in discrete periods of time, an amount of food that's definitely larger than most people would eat in a similar period of time under similar circumstances, and the sense of lack of control over eating during the episode. So feeling as though one cannot stop or control what or how much one is eating. And again, all of this criteria is from the DSM-5. So Sarah, she binges in secret. However, we're not given any information of what that looks like and how much that is, like I said before. So although she does have recurrent episodes of binge eating, we can't definitively say that she meets this criteria because of the lack of information in the case study. Again, I do believe that if I were able to talk to her and get a little bit more information, I would likely be able to say that she meets this. But again, I can't assume anything. So as of right now, she does not meet A. And then binge eating episodes are associated with 3 or more of the following: eating much more rapidly than normal, eating until feeling uncomfortably full, eating large amounts of food when not feeling physically hungry, eating alone because of being embarrassed by how much one is eating, and feeling disgusted with oneself, depressed, or very guilty after overeating. So thinking back on Sarah, we do not know how fast she's eating. We don't know how she feels after eating if she is uncomfortably full. We aren't really sure if she's hungry at the time of the binging. We know that she eats alone, but I can't 1000% say that it's because of being embarrassed by how much she's eating, or if it's due to her feelings about something else. So, say she is embarrassed that she's having a relapse, not embarrassed by how much she's eating, or something of that nature. But we know that she is eating alone and feeling disgusted with oneself, depressed, or very guilty after overeating. So, Sarah has depressed mood tendencies, and her emotions are very all over the place, and they're described as a yo-yo. So that leads me to believe that yes, she does meet this, but it doesn't say specifically that she feels depressed after her binges. It just says that she feels depressed, period. So, yeah, I can't really say that one either. Marked distress regarding binge eating is present. Yes. The binge eating occurs on average at least 2 days a week for 6 months. We don't know. We aren't given a timeline or the consistency. And the binge eating is not associated with the regular use of inappropriate purging, fasting, exercise, and does not occur exclusively during the course of anorexia nervosa or bulimia nervosa, which, yes, she is not purging or exercising excessively. So, yes, she also meets that one. The severity specifiers range from mild to extreme, which again we're unable to determine as of right now due to the limited information about Sarah's binging habits. Binge eating disorder is the closest diagnosis that I came to in regards to her eating habits, and it really does seem that most of her distress is coming from the binge eating, especially just because, I don't know, it caused her to she lost her long-term relationship because of it. She was secretive, she was irritable, she had a depressed mood during that long-term relationship, and then afterwards she was scared to get close to someone because she didn't want to divulge her binging. And so this kind of caused her to retreat, and I think that if she kind of was able to talk more openly about her binging, I think that that would kind of help a lot of her other symptoms. And specifically, since she's not purging anymore, she doesn't really have that release. And she uses binging as her coping skills, but she doesn't have the release afterwards, which could very well lead to her moods. But yes, binge eating disorder was the closest diagnosis that I came to as of right now in regards to her specific diagnostic criteria. Now, if we are kind of thinking more along the lines of diagnosing for insurance purposes and needing a diagnosis from the beginning that we can justify and we can kind of write down and give to insurance in order to be able to bill, I came to the conclusion that adjustment disorder with depressed mood would be able to kind of be justified. Again, I would need to speak a little bit more to Sarah just to kind of understand exactly what's going on, but I think that if I was able to do that, I would come up with a completely different diagnosis anyways. So for adjustment disorder, the development of emotional or behavioral symptoms is in response to an identifiable stressor occurring within 3 months of the onset of stressors. Now, if we're thinking about trying to justify this there are many instances that could be identified as a stressor in Sarah's life. Um, so, first of all, she almost died due to her laxative use and her overdose. So, that alone very well could be a giant stressor in her life. She lost her long term relationship and she no longer is close with her family. She's completely isolating herself from her family. She had to leave college due to her hospitalization. Um, and now she's just working a retail job that we know, or we don't know, I guess, but we can kind of guess wasn't what she was going to school for because she's a sales associate for a major retail chain. So, really, any of these, we could kind of talk to her and I'm sure could be identified as a stressor in her life. Now, we can't really say for a fact that this causes her to binge, or that this causes her moods to change, and that's the reasoning that she does binge. But I mean, she definitely has stressors in her life, and we would just need to talk to her to see kind of which ones really are impairing her the most. Um, and then these symptoms or behaviors are clinically significant as evidenced by one or both of the following, which are marked distress that is out of proportion to the severity or intensity of the stressor, taking into account the external context and the cultural factors that might influence symptom severity and presentation, and significant impairment in social, occupational, and other important areas of functioning. So again, we would need to talk to Sarah to kind of see exactly what the stressor is that is impairing her the most. However, I do believe that her symptoms and behaviors are clinically significant. Um, and I mean, it's very much impairing her life. It's impairing her in her social setting, her romantic relationships, her familial relationships, her occupation, um, her drive to go back to school, her isolation. So it's definitely kind of impairing her life. Then the stress related disturbance does not meet the criteria for another mental disorder and is not merely an exacerbation of pre existing mental disorder. So, yes, she meets this one as well. She just meets this one. The symptoms do not represent normal bereavement. No, they do not. Once the stressor or its consequences have been terminated, the symptoms do not persist for more than an additional 6 months. We don't know yet. We aren't really given the information on exactly how long she's gone in between relapses, how often she thinks about the stressors in her life, etc. And then I chose with depressed mood because the qualifications to kind of be able to diagnose her for this is low mood, tearfulness, and feelings of hopelessness are very predominant. And she does have very low mood. She does feel hopeless, and these do significantly kind of show up in her life. As it was stated in the case study, it seems as though her emotions really are all over the place and that she does have chronic depression and suicidal despair and ideation. It doesn't say if she has any plans or anything, but it does say that she has depression and suicidal despair. Again, this would kind of be used just off the get go, like if we need a diagnosis for insurance purposes. I don't believe that this is the most accurate diagnosis for Sarah, but as of right now, I just don't have enough information to be able to accurately diagnose her with anything else. Next, I'm going to go into treatment planning and levels of care. So, the level of care that I thought was the most appropriate for Sarah is intensive outpatient treatment, which is the ASAM level 2. At first, I kind of thought about just outpatient treatments, and then I kind of started thinking about her frequent relapses, the intensity of all of this on her mood, and how much it kind of impacts her mood, and specifically just the chronic depression and suicidal despair pushed me a little bit more towards more of an intensive outpatient treatment rather than just simply outpatient treatment. She also had a past hospitalization, so that kind of led me to rule out either partial hospitalization or just inpatient. Um, she's not she's not currently purging anymore, and she's not taking laxatives anymore, and she doesn't have a plan to commit suicide. So I, at the moment, don't believe that I can justify sending her to a hospital. Um, and intensive outpatient treatment typically consists of 3 groups per week, 3 hours per session, as well as weekly individual and family sessions. And the primary modality is group counseling. I personally believe that this kind of treatment and the intensity that it has and brings is going to be extremely beneficial for Sarah. She's able to still work and stay at home, and due to how often Sarah will relapse, the increased structure seems a little bit more necessary. Um, and then also, I love that the primary modality is group counseling, and that family counseling is also involved because she has been isolating herself from her family, and they do seem as though they want to help based on the wording in the case study. So I think that this could kind of help provide information for both Sarah and her family in order to, I don't know, kind of just shed more light on exactly what Sarah is going through and make her not as alone in this journey. Of course, I would need more information to kind of accurately determine the level of severity that Sarah has in each of the dimensions that are needed. Um, and there's not enough information to allow me to accurately determine without assuming anything for areas such as detoxification, biomedical complications, and readiness to change. I don't believe that there is any severity, but again, I can't assume without knowing for sure. And then for emotional and behavioral conditions and relapse potential, I believe that there's a mild severity based on the information, but again, I would need to just ask her more questions and kind of get more of a gauge of exactly what's going on. And then for recovery environment, I don't have nearly enough information to state my opinion on any level of severity for that one as well, just because I don't really know exactly where she lives. I don't know who she lives with. I don't know what her day to day life looks like. So I'm not sure what her recovery environment looks like. But based on all of that, I do believe that intensive outpatient treatment is the very best option for Sarah. So, the first treatment approach that I want to talk about is cognitive behavioral therapy, or CBT, and this would be used in more of that individual therapy. Um, so, Sarah uses binging as her main coping mechanism and describes her emotions as a yo yo. So, this alone is what kind of led me to CBT. Um, and then also, her binging has led to chronic depression and suicidal despair. And CBT can help develop healthy attitudes towards food along with new approaches for coping with stressors. There are many structured manuals used to treating binge eating disorder, or just episodes of binging in general. And one that I kind of specifically want to talk about is one that was made by Mitchell, and I cited it below. But this specific one consists of 14 weekly sessions and focuses on goals such as interrupting binge eating, establishing healthy eating patterns, identifying and restructuring faulty thoughts and negative feelings, and identifying more effective coping strategies. So, these alone, just in my paper on exactly what I thought goals that would be good for Sarah would be, it touched on both of them. So, her binge eating is very clearly a problem in her life, and she admits that it's a problem. And she uses it as a coping strategy. So, that would kind of touch on that last point that I just talked about, identifying more effective coping strategies. CBT also is extremely beneficial because there's homework assigned, and an example of this for Sarah that I personally would assign would be maybe completing like a self-monitoring sheet in between sessions in order to document and track binges and also emotion changes. Again, this is mainly just because I truly don't have the full idea of exactly what a binge looks like for Sarah or how often they happen. So this self-monitoring sheet would kind of give me that exact look at her day to day life in between sessions with her. And I would also do CBT with a large emphasis on knowledge and understanding of the symptoms and behaviors. And this will begin to help Sarah truly see the cues that lead up to binges, along with exactly what's going on inside of her brain, with tools to cope with it in a more healthy manner. This quote I just thought was very, I don't know, kind of, it really leads into the next treatment approach that I'm going to talk about. So the quote is, exposure to one's own problems and pain as they are experienced in the lives of others facing you can bring about change of an unforeseen kind with far-reaching consequences. So just going right into the next topic is group therapy. So, kind of being exposed to other problems and pain, as exactly what the quote says, as it's experienced in your own life, can kind of show you exactly what's going on without really making it seem unreachable or unrealistic. So, going right into group psychotherapy, Sarah's been ignoring and isolating herself from her family. Her romantic relationships never get past a certain point due to her secrecy and inability to open up. And Sarah kind of seems ashamed of her binging based on the secrecy surrounding it, along with her depressed mood and continued isolation. So, utilizing group psychotherapy in addition to individual therapy has the potential to help her recognize that the way she acts is okay and is allowed to be talked about. One of the major aspects of group therapy is talking about individual stories, and it seems as though Sarah doesn't really feel comfortable opening up to the people in her life regarding her binging. Um, so, by being open in this kind of group environment, which is filled with individuals who understand exactly what she's going through and can offer support, might be exactly what she needs to begin that process of feeling confident and comfortable enough to open up in her day to day life. Um, Group therapy is extremely beneficial in decreasing the frequency of binge eating. And also, she would be able to see people who are at all different stages of treatment. So that's another reason that I kind of went with intensive outpatient, because group therapy is a huge point in intensive outpatient. Um, and this would kind of give Sarah that confidence that she really needs, and also give her just the exposure and the knowledge and the hope that she can kind of get a wrap on everything, because she did seek out help on her own. She knows that what she's doing isn't healthy. Um, and although she kind of came to justify her coping skill as appropriate, I think that kind of talking to other people who have been through a similar situation would really shine a new light on everything for her. Thank you so much. These are my citations. All right, have a good day.